Hello everyone, this is Dr. Singaram, your Pediatrics faculty. In this session, I am going to discuss about INI-CET May 2024 recall question discussion in Pediatrics. Before we get started, this time in INI-CET also, we got good number of questions in Pediatric subject and the questions were having the usual type only. One set of questions was related to basics in pediatrics, where if you have attended the clinical ward rounds very correctly and have made the observations correctly, you could have answered good number of questions. Second set of questions was related to previous year topics. It was not the same question, but the topics from the previous year, as we always emphasize in the classes, that had also a good number of questions. And lastly, as with any INI-CET exam, we had few new questions as well. Okay, right. So let us get started with the discussion. The first question was from a usual expected topic, which was on the topic of dehydration in a child with diarrhea setting. Okay, right. Which of the following holds true for some dehydration in a child? So this was a question related to some dehydration, and you can see that there were four set of features which was given. One was related to the thirst, second one was mental status, third is skin pinch, and fourth is the sunken eyes. So we all know that in diarrhea, no dehydration, some dehydration and severe dehydration is there. This is related to some dehydration. If you look at the first one, thirst is increase, which is a true statement and is an important finding in some dehydration. What about the mental status? It is not lethargic in some dehydration. Letharginess or unconsciousness is seen in severe dehydration. Very important. It is seen in severe dehydration. Okay, right? In some dehydration, actually the child is irritable or restless. Okay, child is not lethargic. So that is wrong. What about skin pinch? Of course, it is delayed only. Delayed is also called slow reaction time in skin pinch, which is less than or equal to 2 seconds, which is a correct finding in some dehydration. What about the fourth one? Sunken eyes are definitely present in case of some dehydration as well. So if you look at the answer for this question, it is A, C and D, which fits into the option B. A, C, D only will be the answer for this particular question. So just a quick recap of the three types of dehydration with respect to the four parameters given in the question. In no dehydration, child is alert. In some dehydration, child is irritable or restless, and in severe dehydration, child is lethargic or unconscious. Eyes are normal in no dehydration, sunken in case of some dehydration, and very sunken as well as dry eyes in case of severe dehydration. Thirst, child is not thirsty means normal. In case of some dehydration, child is thirsty and eagerly drinks a lot of water. That is what is for some dehydration, very characteristic feature. And third, in severe dehydration, because the child is lethargic, child is not able to drink water. Skin pinch is quick in case of no dehydration. Some dehydration it is slow or delayed, which is less than or equal to 2 seconds, and in severe dehydration it is very slow, which means more than 2 seconds. So this is a quick recap of the four aspects of dehydration asked in this question. So the answer is option B, which was having A, C, D statements which are correct for some dehydration. There was one more question about dehydration, but this time in a child with malnutrition was the question. What is that? Which of the following is a reliable sign of some dehydration in severe acute malnutrition? See, before I answer this question, you should all understand one thing, that in the setting of malnutrition, dehydration has some difficulties for assessment as well as for treatment. Okay, look at this statement from the textbook, OP Guide textbook only. In a child with SAM and dehydration, the dehydration tends to be overdiagnosed, very important, okay, and its severity is overestimated in severely malnourished children. Okay, right? There are so much of difficulties in a child with malnutrition, so that is why dehydration tends to be overdiagnosed. Okay, right. Now let me take you back to that question itself. Which is a reliable sign of some dehydration? Okay, right. Now if you look at the four option, look at the fourth option. What is that? Altered sensorium is absolutely wrong for this particular question, because it's a feature of severe dehydration and not some dehydration. So that is going to be out of answer for this question. Look at the other three options: increased thirst, sunken eyes and skin pinch that goes back slowly. All are features of some dehydration only. But in a child with malnutrition, there is low subcutaneous fat. You all know about it. And because of this low fat itself, child can have a sunken eyes. Okay, right? Or what I am trying to say is, sunken eyes could be a part of malnutrition itself, or it could be a part of dehydration also. So is that a reliable sign of some dehydration? No, it is not possible, because it may be due to low fat itself, child is having sunken eyes. What about the next option, C? skin pinch that goes back slowly. Of course, it's a feature of some dehydration, but the skin pinch is also affected by the amount of fat in the body, and in a child with malnutrition, there is low fat that itself can make the skin pinch to go back slowly. So, this is also not a reliable sign of some dehydration. So, what is going to be the obvious answer for this question? It is increased thirst, which is the reliable sign of some dehydration among the options which is provided. Okay, right. Look at the wordings from the textbook again. The second point about salmon dehydration is loss of elasticity of the skin may either be due to loss of subcutaneous fat or loss of extracellular fluid in dehydration. So, that means if you are doing skin pinch and if it is delayed, you cannot be sure whether it is due to loss of subcutaneous fat or whether it is actually due to dehydration. So, that is why it becomes an unreliable sign in dehydration. Now, look at the next point. Reliable signs of dehydration in a child with malnutrition include dry oral mucosa, presence of thirst, which was the answer for the question, and weak pulses and oliguria. Of course, weak pulse and oliguria is seen only in severe dehydration. Okay, right. In our question, it was about some dehydration in a child with malnourished child. So, the obvious answer is increased thirst is the answer. Okay, right. So, that was about the second question on dehydration. Moving on to the next question. This is something related to basics of pediatrics, which is related to anthropometric measurement. Here, the question was related to head circumference increase. How much is the rate of head circumference increase in the first 3 months of life in terms of centimeter per month? You have to answer. Okay, right. This is a very straightforward question. So, let me just discuss the facts first and then we'll answer this question. Okay, head circumference at the time of birth is roughly around 33 to 35 centimeters. If you take the average, it would be something like 34 centimeters. That is what. In the first 3 months, there is an increase of 2 centimeter per month for the first 3 months. Then for the next 3 months, it is a little bit slower, 1 centimeter per month. Then after that, for the next 6 months, it is 0.5 centimeter per month. This was happening in the first year. In the second year, there is a total increase of only 2 centimeter in the full year. Okay, right? And then after 2 years, okay, right, there is a minimal increase in head circumference only. And when is the adult value of 52 centimeters attained? It is by the age of 12 years. So, these are some of the facts related to increase in head circumference. Now, the question was related to how much is the increase in the first 3 months of life. The answer is going to be increase in 2 centimeter per month, which is the option B for this particular question. Okay, right. Then one more question related to anthropometry. This is something related to evaluation of a child with short stature. 15-year-old boy is presenting with short stature, and on examination his upper segment lower segment ratio is 0.8:1. So, this is a question focused about upper segment lower segment ratio. Okay, right? And some value is given and you have to choose your answer based on that value. Value is 0.8:1. Before we answer this question, okay, right, let us just quickly go through this upper segment lower segment ratio, that is US-LS ratio. What is a normal US-LS ratio in a 15-year-old child? Okay, right? You know that after the age of 10 years itself, after the age of 10 years, the ratio is 0.9:1. And in the given question, the child is 15 years, but the ratio is 0.8:1. That means the ratio is decreased. Which is actually decreased? It is the decrease in upper segment. Okay, remember we are comparing upper segment with lower segment. The ratios decrease means the upper segment is actually decreased. Now, when we talk about upper segment, it is basically the trunk, which is composed of the spine or the vertebra, right? And when we talk about lower segment, it is nothing but the lower limbs, which is nothing but long bones in the lower limbs which contribute to lower segment. So, in this particular question, we were discussing that the problem is in upper segment, which is a short upper segment. That means, in this particular child, the trunk is short. Okay, right? So, trunk is short means there is some problem in the vertebra. Now, I will take you back to that options. Tell me which is the possible answer. Vertebral problems are fitting into which option? Yes, it is spondyloepiphyseal dysplasia. okay, right, where the vertebral formation is getting affected, that results in a short vertebra, and that is why you get a short upper segment, okay, right. If you look at achondroplasia, okay, is characterized by short limbs, short limbs. So, it is a lower segment which tends to get affected in case of achondroplasia. That cannot be the answer for the question. In growth hormone deficiency, the US-LS ratio is normal, right. So, that can never be the answer for this particular question. In hypothyroidism also, you are expecting short limbs. So, all those options are ruled out, and answer and option A is the answer for this particular question, okay, right. So, I hope you got an approach to this particular question, and these are the lines from the textbook as well. A decrease in US-LS ratio is seen in spondyloepiphyseal dysplasia as well as vertebral anomalies. So, the correct answer for this question is option A. Now, I want you to add two more points about spondyloepiphyseal dysplasia. It is a condition characterized by a decrease in type 2 collagen synthesis. This point can be asked in your future exams. So, please make a note of this. Type 2 collagen synthesis. Second, I told you obviously there is a vertebral abnormalities present in this particular child, and along with that there is thoracic kyphoscoliosis is also a feature of spondyloepiphyseal dysplasias. These may be potential questions in future, so you should make a note of it. So, that is about this particular question. Moving on to the next one. It is a question related to nutrition rickets, which is not seen in nutrition rickets. You all know that nutrition rickets is due to vitamin D deficiency, correct? And whenever there is vitamin D deficiency, obviously there is going to be low phosphate. Actually, this option A is not phosphorus, it is phosphate, and also due to vitamin D deficiency, there is a decreased calcium as well, okay, right, because the absorption of calcium and phosphate is decreased. So, there is low levels of calcium and phosphate, and whenever there is low calcium, okay, it will automatically trigger increased levels of parathyroid hormone release from the parathyroid gland, and due to this effect of parathyroid hormone, what will happen? The calcium can come back to normal also. So, remember, in nutritional rickets, you can get either a low calcium or a normal calcium, but the normal calcium is due to the effect of increased parathyroid hormone. So, if you see in this question, low phosphate is seen in nutrition rickets, normal calcium can also be seen in nutrition rickets, and the last one, high PTH, is also seen in nutrition rickets. So, the obvious answer for this question is option C, which is urine calcium to creatinine ratio. You can see that it is written more than 15, they are simply telling you that it is increased. The normal calcium creatinine ratio in children is less than 0.2 milligram per kilogram. Okay, in this particular question, very high values of more than 15 is given. It means the urine calcium is increased. Okay, urine calcium is increased. But actually, in case of rickets, the urine calcium excretion is decreased. So, the ratio is going to be low only for this particular child. So, the obvious answer for this particular question is option C. Now, one more point I want you to remember is in which condition the urine calcium creatinine ratio can be increased. You can see more than 15 is increased ratio. Increased ratio is seen in case of idiopathic, yes, any answer? Idiopathic hypercalciuria, idiopathic hypercalciuria. In fact, in this condition, calcium creatinine ratio estimation serves as a screening test for this condition also, okay, right? Another potential question which you can make a note of, okay. So, that is about this particular question, which is a very straightforward question about nutrition rickets. Then we move on to one more question about anthropometry and malnutrition. Consider the following statements in anthropometry for a 5-year-old child and give your comment on the diagnosis, right? You can see the options, okay, right? The question is, what is the diagnosis according to WHO criteria for malnutrition? So, it is all related to malnutrition and WHO criteria, okay. Weight for age is given in terms of standard deviation, height for age below minus 2.5 standard deviation, weight for height below minus 1.7 standard deviation, okay. These are the options which are given. Now, first thing you have to make a note of this is, what is the WHO criteria for malnutrition in terms of standard deviation values, right? That is the first thing you have to answer. Then we will come back to the question. Okay. Low value or the cutoff for malnutrition is a value below minus 2 standard deviation. This is a standard definition from WHO. Below minus 2 standard deviation only is called as malnutrition. Okay, right. Then severe malnutrition is defined by a value below minus 3 standard deviation. This is the second concept you have to remember, second fact you have to remember. Okay. Then what is acute malnutrition? Acute malnutrition is low weight for height, W by H. And acute malnutrition is also called wasting. Okay, acute malnutrition is also called wasting. Then what is chronic malnutrition? Chronic malnutrition is low height for age, H by A. And chronic malnutrition is also called stunting. These are the basic facts which all of you should be knowing about. And once we have revised this, we will again go back to the question. You can see in this particular question, weight for height is below minus 1.7 standard deviation. So, it does not fit into the criteria for malnutrition itself. So, we will just cut off that point. Whereas, the other two things, height for age and weight for age are given. And in our classification, height for age is only given importance, which is below minus 2.5 standard deviation means it is decreased, it is malnutrition. And because height for age is less, it is a case of chronic malnutrition. And that would be the better answer for this particular question. Please remember, we will not take into account weight for age while defining malnutrition. Low weight for age. I agree, this weight for age below minus 3.2 standard deviation is low only, but it is simply called underweight. And please remember, this low weight for age or underweight can be seen in both acute as well as chronic malnutrition. That is why with that parameter alone, we cannot be able to differentiate acute and chronic malnutrition. So, it is not considered for this particular question. So, the answer for this question is chronic malnutrition because it is a height for age which is affected in the setting of malnutrition. So, for this question, option B is the correct answer. One more way of saying this question is moderate stunting also. Why I am saying moderate stunting? Moderate is because the value is between minus 2 to minus 3 standard deviation. Remember, severe means it should be below minus 3 standard deviation. This is only minus 2 to minus 3. So, I will call it moderate malnutrition, and the word for chronic malnutrition is stunting only. So, that is why the other way of expressing this particular question is it is also called moderate stunting. That is also possible. Okay, right. Moving on to the next question. This is something related to neonatology section where a question was asked related to Downey scoring. See, Downey score is useful in the assessment of children with or neonates with respiratory distress. See, whenever I say respiratory distress and score, the first thing which comes to your mind is Silverman scoring, which is one of the important scoring systems for respiratory distress assessment in preterm neonates. That is what I have told you. Now, this Downey scoring is useful in the assessment of term babies with respiratory distress, and that was asked this time in the exam. And for Downey scoring is concerned, you don't need to know the full scoring system. You just need to know the components only. Okay, right? And that is what this question was exactly asking about. Downey score includes which of the following? It's a multiple correct choice question. So, A, B, C, D is given. You have to choose all the correct ones. Okay, right? Now, the complete name of this Downey scoring is called Downey's Vidyasagar score, right? And it is very easy to remember also. Think about a neonate with respiratory distress. What all features you can expect? Number one, I will expect is respiratory rate to be increased. So, that is component of Downey score. Second thing, as the respiratory rate is increased, what will happen? There will be presence of chest indrawing or retraction. That is the second component of Downey score. Think about the third component. If the respiratory distress becomes very severe, what other possibilities can happen? Child can have a cyanosis and child can also have grunting, which is also included in Downey score. And last one, which is additional thing you can remember, is the air entry tends to be compromised when the baby is having respiratory distress, and that is also included in the Downey score. So, 5 components are there, and if you go back to this question, respiratory rate is included, cyanosis is included, retractions is included, feeding is not a part of Downey score. So, A, B and D are the correct options. So, which is fitting into the last option for this particular question. So D, A, B, D are the correct components out of the option given for Downey scoring, which was asked in this particular exam. Then next question in neonatology section was related to insure technique is used in which of the following condition. Remember, this is a very common, it's a repeatedly asked question as well. Insure is a short form for an expansion. What is that? Intubation, that is what is IN. After intubation, you give surfactant, that is what is for SUR, surfactant, and after the baby's condition improves, it is extubation. If you know this expansion, the question becomes very easy. What is that? Yes, it is useful in respiratory distress syndrome, which is due to surfactant deficiency, right? It is usually a condition of respiratory distress occurring in preterm babies. Okay, right? So, the straightforward answer for this question is RDS or respiratory distress syndrome. Now, please remember, not every baby with respiratory distress syndrome you are going to give surfactant. There are few important indications. Only in a baby with severe RDS or respiratory distress syndrome, you are going to provide surfactant. Look at these AIMS guidelines. Preterm neonates with increasing FiO2 requirements and worsening respiratory distress on CPAP must be given intratracheal surfactant. So, this is something important. Only for babies with severe RDS, you should give surfactant treatment. Okay. So, the answer for this question is option A only. Okay. Moving on to the next question, again related to newborn. It is a new question. Okay. Which of the following is not a suitable method for free flow oxygen delivery to a newborn baby? Remember, free flow oxygen delivery is one of the simplest and one of the effective methods of providing oxygen to a baby. For example, a baby with respiratory distress. Okay, right? Now, this question is which is not a method of free flow oxygen delivery for a newborn baby, right? Look at the option. These are all simple ones only. Oxygen tube kept close to the baby's nose and mouth. Definitely one of the ways by which we can give free flow oxygen. So, that cannot be the answer for the question. Oxygen mask placed over the baby's mouth and nose. That is also another common way of giving free flow oxygen to the baby. Look at the third option. Self-inflating bag attached to an oxygen mask placed over the baby's mouth and nose. This is wrong option and the answer for this question. Why? Because the self-inflating bag, okay, is used for providing positive pressure ventilation. It is not for providing free flow oxygen to the baby. This is something which you have to remember very correctly. So, during neonatal resuscitation, when the baby requires bag and mask ventilation, we can use this self-inflating bag attached to the oxygen mask, right? But it is not for providing free flow oxygen to the baby. So, that should be remembered very, very clearly. Okay, right. Look at these lines from the resuscitation guidelines. Because the gas or the air does not flow out of the mask unless the mask is being squeezed. That means unless you don't press the bag, the air will not flow out of the bag, right? Very simple concept. A self-inflating bag and mask cannot be used to provide CPAP or free flow oxygen. Very, very important linings from the resuscitation guidelines itself. Okay, right? Then look at the last option. A reservoir bag attached to the oxygen mask kept over the baby's nose and mouth, that can also be used for providing free flow oxygen. This is also mentioned in the guidelines. You can see the next point. Free flow oxygen may be administered through a open reservoir or the tail on some of the self-inflating bags. Okay, right? So, that is also one more way of giving free flow oxygen. So, the obvious correct answer for this question is option C only, because self-inflating bags are never used to provide free flow oxygen to neonates with respiratory distress. So, very simple, and the answer for the question is option C. Okay, right. The next question was one more question related to fluids in children. This time it was related to which is the ideal maintenance fluid in children. Okay, no particular condition was mentioned, it was just maintenance fluid in a child. Remember, maintenance fluids are required in a child who cannot take oral fluids or oral food. Okay, right? Those situations only you are going to give maintenance fluid. So, out of the options provided, which is the correct answer? Is it 10% dextrose plus N/2, that is half normal saline, or 5% dextrose with normal saline, 5% dextrose with N/4 saline, or 5% dextrose with N/5 saline? Okay, right? Now, let us look at few basic principles and then we'll arrive at an answer for this question. Okay, as I already told you, it is given for a child who cannot be fed enteral fluids. Okay, right? Okay, so this is usually in the setting of post-operative or pre-operative patients who cannot take oral fluids. they can be given maintenance fluids. Okay. Second, what is the ideal maintenance fluid? It should be composed of water. It should also be composed of glucose, very important, as well as a major electrolytes. What are they? Sodium and potassium. Okay, right? That is how an ideal maintenance fluid should be, right? So, if you look at the usual fluids available, we have the isotonic fluids. What is the usual one? It is a normal saline. Of course, ringalactate also, but what we usually use is normal saline. Okay, right? So, isotonic fluid like a normal saline is okay. It will take care of the water as well as the sodium, but there is no glucose and potassium. So, what you should use? To the normal saline, you have to add dextrose. D5 means 5 percentage dextrose should be added, and along with that potassium in the form of potassium chloride also should be added in the form of 10 to 20 milliequivalents per liter is usually added to the normal saline to add up for the potassium in normal saline. Okay, right? This is a recommended maintenance IV fluid in children. Okay, so it is normal saline with dextrose with added potassium. So, out of the options which are given, option B is the correct answer. So, ideally they should have included potassium also, because normal saline does not contain potassium. So, it should be separately added to the normal saline, but it is not given in any of the option. So, we will just take into account the dextrose as well as normal saline. So, the correct answer for this particular question is 5% dextrose plus normal saline, which is option B for this particular question. Moving on to the next question. It is a new question. Cannabinoids are not indicated in which of the following condition? Okay, right? If you look at the condition, Lennox-Gastaut syndrome, Dravet syndrome, tuberous sclerosis, Rett syndrome, all can be associated with seizures, and you can easily understand that cannabinoid is not a usual anti-epileptic which we use in children. So, this is purely a new question. Okay, right? So, before I answer this question, first remember, cannabinoids in pediatric seizures are not the first line treatment. They are only adjunct or add on to the already given medication. For example, you are using valproate and lamotrigine or lamotrigine, something like that, as an anti-epileptic in a child. As an add-on treatment, you can give cannabinoids. It is not the first line treatment. And second important point is, the mechanism of action of cannabinoids is not known. People thought that it was acting through cannabinoid receptors, but that is not yet proven. So, exact mechanism of action is not known. And you can see the second and third points which are taken from Nelson textbook. What is written? FDA has approved CBD. CBD is cannabinoid and fenfluramine for treatment of seizures in the setting of two syndromes. What are they? Lennox-Gastaut syndrome or Dravet syndrome in children more than the age of 2 years. So, in these two conditions, you can use cannabinoids. Then one more line from Nelson textbook, look at the third point. FDA also approved cannabinoid CBD and everolimus to treat seizures in a tuberous sclerosis child more than the age of 2 years again. Okay, right? So, you can see that from the Nelson textbooks, it is very clearly written that cannabinoids can be used in Lennox-Gastaut syndrome, Dravet syndrome, as well as in tuberous sclerosis. So, what will be the answer for the question? It is not used in Rett syndrome. So, option D will be the answer for this particular question. Okay, right? So, that is about this new question about cannabinoids in pediatric seizures. Moving on to the next question. Which of the following MRI findings will be seen in a child with spastic quadriplegia? This is in the setting of cerebral palsy. They have asked this question. One type of cerebral palsy is characterized by spastic quadriplegia, where there is spasticity in all 4 limbs. Okay, look at the options: basal ganglia calcification, periventricular leukomalacia, cerebellar degeneration, and multicystic encephalomalacia. So, this is basically a clinico-pathological correlation type of question, where they have given you the clinical finding and asking you what is a pathological finding in the brain. You can pick it up on an MRI finding. Okay, basal ganglia calcification can result in damage to the basal ganglia permanently and can result in cerebral palsy. But what will be the type of cerebral palsy you will get? You will get extrapyramidal cerebral palsy. You will get extrapyramidal cerebral palsy characterized by the movements like chorea, athetosis and all, and it is also called dyskinetic cerebral palsy, which is not what is asked in the question. So, cannot be the answer for this question. Okay, right. Then periventricular leukomalacia is typically seen in preterm children, and it is characterized by spastic, what type of finding? Diplegia, spastic diplegia and not quadriplegia. So, it cannot be the answer for this particular question also. Cerebral degeneration is obviously not possible because you will not get spastic quadriplegia in this case. You will get signs of cerebellar dysfunctions, right? Not quadriplegia. So that is obviously wrong. So the correct answer for this question is multicystic encephalomalacia, which can be seen in term babies who had suffered birth asphyxia and later going on to develop cerebral palsy, which will be the answer for this particular question. So just a quick recap of the neuropathology correlation in cerebral palsy depending on the type of cerebral palsy. In case of spastic quadriplegia, which was the question, you can get multicystic encephalomalacia. One more thing you can get is parasagittal infarction also. Spastic diplegia, I have already told in the question, you get periventricular leukomalacia. Extrapyramidal means involvement of basal ganglia, which is seen in the setting of kernicterus, which is nothing but high levels of bilirubin damaging the brain. That can result in extrapyramidal cerebral palsy, where the basal ganglia is damaged and you can get features like chorea and athetosis. It is also called as dyskinetic form of cerebral palsy also. Okay, so the obvious answer for this question is option D. Multicystic encephalomalacia correlates with spastic quadriplegia. Moving on to the next question. A 10-year-old boy presents to you with sexual maturity rating of 5, height age more than chronological age, and hyperpigmentation, short stature and blood pressure of 180 by 110 millimeters of mercury. Which enzyme is deficient in this condition? 11 beta hydroxylase, 21 alpha hydroxylase, 3 beta dehydrogenase and cholesterol side chain cleavage enzyme deficiency. If you look at the options, you can quickly note what condition they are talking about. Yes, it is a condition of CAH or congenital adrenal hyperplasia, which is characterized by deficiency of adrenal enzymes for the steroid synthesis, because of which only child develops numerous clinical features. Okay, right? So, in this particular question, we are going to put an answer based on the clinical features and which enzyme deficiency does it correlate. So, we will first analyze the clinical features. This is a 10-year-old boy who is having sexual maturity rating of 5. What is the meaning of sexual maturity rating 5? It is like the advanced stage of puberty at the age of 10 years itself. What is the meaning of that? He is having precocious puberty. He is having precocious puberty. That is one of the important clues in the question. Second important feature given in the question is hyperpigmentation. Remember, in all cases of congenital adrenal hyperplasia, there is increased levels of ACTH, which is the reason for hyperpigmentation occurring in child with congenital adrenal hyperplasia. So, that is explainable. Then we have short stature. Not only that, blood pressure of 180 by 110 millimeter mercury, which clearly tells you that this child is having hyperpigmentation. Hyperpigmentation. Okay. So, now in this particular question, what will be the answer? Is it 11 beta, 21 alpha hydroxylase, 3 beta hydroxyurea deficiency or cholesterol side chain cleavage enzyme deficiency? The obvious answer for this question is 11 beta hydroxylase deficiency. How? I am just going to quickly recap this congenital adrenal hyperplasia with this adrenal gland biosynthesis pathway. Okay, our topic of interest is 11 beta hydroxylase deficiency. This is 11 beta hydroxylase. When this is going to be deficient, what is also going to be deficient? Aldosterone is going to be deficient. Cortisol is going to be deficient. And you know that the moment cortisol becomes deficient, it will trigger increased ACTH response from the pituitary, and that will come and act on the adrenal gland, which will cause stimulation of the adrenal gland. Okay, now when you look at the last step, which is what is occurring here, I am talking about this step, what is going to happen? The testosterone production will get increased. Okay, right? Why? Because there is no 11 hydroxylase deficiency in that pathway, or that enzyme is not involved in that pathway, and due to ACTH stimulation, the adrenal gland function is increasing. So that is why the testosterone production increases in this particular situation. This testosterone increase is the direct reason for precocious puberty which was occurring in this particular boy. The second thing to be noted is aldosterone is low in this particular child. That is fine. But if you look at 11-deoxycorticosterone, which is the metabolite or the intermediate before the blocked enzyme step, what is going to happen to that level? That will be increased. I am writing 11-deoxycorticosterone level is increased. Now, this metabolite has mineralocorticoid property, and due to which only there is a hypertension occurring in this particular child. So, the clinical finding of hypertension along with the precocious puberty correlates very well with the diagnosis of 11 hydroxylase deficiency in this particular child. Okay. So, a quick recap, 11 beta hydroxylase deficiency is characterized by high androgen, which can result in precocious puberty in boys and ambiguous genitalia or virilization in case of girls. Then high ACTH, I have already told you, is a reason for hyperpigmentation. And third, blood pressure is high. This is due to the increased levels of deoxycorticosterone. Okay, right? So, very well, easily explainable. So, the answer for this question is option A, 11 beta hydroxylase deficiency, right? Okay. Now, moving on to the last question, which is about febrile seizure. Okay, right? Of late, in the last 2 to 3 years, so many questions have been asked from febrile seizure, making it one of the most important topics in the entire pediatric section. Okay, this time also there was a question which is a multiple correct choice question about febrile seizure. So, we will analyze the statements individually. First statement A, simple febrile seizure or generalized tonic-clonic seizures not lasting for more than 15 minutes, occurring in a child with a fever of 38 degrees or more, between the age of 6 months to 5 years and only once in 24 hours. This is an absolute correct statement, which is a typical description of simple febrile seizure, also called typical febrile seizure. If this is not satisfied, for example, the child has seizure duration of more than 15 minutes, recurs within 24 hours, then it is called complex febrile seizure or atypical febrile seizure. So, the given statement A is correct. Chance of recurrence after one episode of febrile seizure is 54. This is a wrong statement because the general chance of recurrence of febrile seizure is only 30%. Look at these lines from Nelson textbook regarding febrile seizure. The first point, febrile seizures occur in approximately 30% of those experiencing a first episode. It is not 54%. So, that is why I said that statement is wrong. It can be 50%, not after the first episode, after 2 or more episodes. Okay, right? So, that is why this statement B is definitely wrong. Look at the statement C. Long-term anticonvulsants are not indicated in simple febrile seizure. This is a true statement. We don't give long-term anticonvulsant for febrile seizure. What do we do at the most? If a child is having repeated seizures, okay, or high risk for recurrence in future, what we may give is intermittent anticonvulsant prophylaxis. It is not long-term anticonvulsants actually, right? So, this is a correct statement only. Again, look at Nelson textbook, the second statement here. Use of continuous anticonvulsant therapy is not justified because of the risk of side effect and the lack of demonstrated long-term benefits. So, this statement C is a correct statement. Look at the last statement. CT is indicated in patients in whom there is a high risk of structural abnormalities, metabolic disturbances within the age of 3 years. This is also a correct statement. Look at it. A simple febrile seizure, we will not do brain imaging like CT or MRI because we are not expecting any structural abnormalities in the brain. However, if you are expecting a structural abnormalities or metabolic problem, it is obviously justifiable to do a CT or MRI brain. So, that is why this statement is correct. Again, look at the line from the Nelson textbook, the third statement here. Workup in a child with a complex febrile seizure, that means it is not for typical or simple febrile seizure, it is only for complex febrile seizure, can include EEG and brain imaging like CT or MRI, particularly if the child is having neurological abnormalities or when you are suspecting underlying neurological abnormalities. Okay. So, this statement is also the same thing only. If there is a high risk of structural abnormalities, definitely you have to do a CT brain in this particular child. So, what are the correct statement? A, C and D are the correct statement which is fitting into the option B for this particular question. So, the correct answer is option B for this question about febrile seizures. Okay, right. So, that was the last question about the pediatrics recall in INI-CET May 2024 exam. I hope this discussion was useful and will be a helpful supplement for your preparation for upcoming exams. So, again I wanted to emphasize the fact that when you prepare for any future exam, take into account the previous year exam topics or the recent exam topics, as well as revise your notes properly, and along with that, basics of pediatrics always contribute to good number of questions in any exam which you are going to appear for. So, with that note, I complete the discussion and I wish you all the best for the upcoming exams.